Hi, I'm Robin Cooper, and I'll be going over this module and learning exercise. But first, let me introduce the players in for this project. In this project, as you can see from the title, exploring the mechanisms leading to symptomatic effects of 4-aminopyridine pharmacological treatments in patients with MS, multiple sclerosis. This is a teaching learning module, and we would like to see how this module interacts with the students and how you feel that this might be effective teaching module. The players involved are Dr. Anne Simone O'Neill. She finished her doctorate in physical therapy here at UK, worked at Cincinnati Children's Hospital, and now she's in North Carolina. Dr. Becky Krall is here at the University of Kentucky, and then myself. And let me introduce Dr. Becky Krall.
Hi everyone, my name is Becky Krall and I am a faculty member in the STEM Education Department in the College of Education. I'm looking forward to working with you and Dr. Cooper and Ann this semester. I will be helping with data collection and analysis.
So you've had your class homework assignment that was already given, and which was basically the pre-survey. And hopefully you've had time to now work through that, and it should have been handed in before we've gone through this exercise. So remember what those questions were that you were given earlier, and we didn't expect you to know the answers for these. This is not for you just testing your abilities to look this information up or anything at this point. This was just to see where we are when we started this module. Okay. And so for the case study, Anne will introduce this.
Hi, I just wanted to introduce myself. I'm Anne O'Neill. I'm a physical therapist that works primarily with the neuropopulation. We will go over the case study a little bit later in this talk.
And here is the case study.
So let's talk a little bit more about this case study. You have your classmate Jane, where she's first demonstrating symptoms of clumsiness, lower extremity weakness, double vision, overall fatigue. You don't see her until the next semester, where she's starting to walk a lot more slowly, seems a little bit more cautious walking pattern, has trouble going up and down the stairs, reporting these pins and needles sensation in her legs, and just overall fatigue. Maybe she had gotten a little bit better between the two semesters, or maybe things are just progressively getting worse. So she's working with her doctor to figure out, what is going on here.
So now we're going to go over the basic neurophysiology of how neuron channels work, types of ion channels, and particularly related with this module with MS in 4-aminopyridine and potassium channels. So we're not covering everything. We're hitting some of the high points that are related to this topic. But we have to make sure everybody's on the same page. So we're going through this exercise. To understand way back how neurons function really came from this wonderful animal called the squid. And why this is such an important animal is that the neurons could be taken out of the squid. And we see some colored here in different colors. The red is a presynaptic neuron, and the green one is a postsynaptic neuron. And the same here with this brown one. Now the green one's presynaptic and the brown one's postsynaptic in this situation. So electrical flow goes this direction. And what happens is this allows the animal to contract its mantle muscles very quickly, shoot water out so the squid can actually propel very quickly. Okay, why these axons are so unique is that they're very large. They're the diameter of your pinky, or say a wooden pencil. And one could take the cytoplasm and squish it out and actually put a wire down inside there and fill it up with whatever solution they wanted to. Tie off the ends, and then you could actually study electrical activity within the neuron itself, within that axon. One could also study synaptic transmission with an intracellular electrode in the presynaptic and another intracellular electrode in the postsynaptic, and understand synaptic communication. So this is one of the first models that was actually used to understand electrical conduction and understanding the ions that move across that, and understanding synaptic transmission at a very detailed level. And it's still used to this day for understanding some of the basic concepts in neurophysiology. Here is a situation where they've actually injected a dye, so you can see the presynaptic neuron, and a dye in the postsynaptic cell. And now you can see that they're communicating to each other. People have put electrodes in the pre and the post cells and actually then stimulated and looked at the shapes of action potentials and understood the properties of synaptic communication. In addition, they looked at the type of currents. What kind of current of ions goes inside the cell or goes out of the cell during electrical conduction? The same for the synapse. What kind of currents go into the cell when synaptic transmission occurs? Okay, to understand resting membrane potential, you might have seen this equation before, the Nernst equation. Let's just quickly go over it. This is for a single ion. This was actually derived from the gas laws. V is the voltage or the membrane potential. R is the gas constant, T is temperature, Z is the ion charge. Say for sodium it's +1, for chloride it would be -1. F is the Faraday's constant. Ln, natural log, or Nn of the concentration of the ion on one side, let's say the outside, versus the concentration on the inside. So what does this tell us? If you have a charged ions across a membrane and you have more on one side than you do the other side, what's that going to do? It's going to develop a voltage difference across that membrane, right? So what is that voltage difference and how do you determine it? Well, this is the equation that would determine that voltage difference due to a charged gradient difference across the membrane. You could also have, let's say we start with the same concentration at the beginning of an ion on both sides of the membrane and have the membrane permeable to a particular ion. And let's say you put a cathode on one side and an anode on the other side, such as a positive pole and a negative pole, and you turn on the charge across these two poles. So you could induce a voltage change across the membrane, and in time, when it reached equilibrium, it would develop a concentration gradient, right? Let's say you had potassium across the membrane. Well, potassium would be attracted to the negative pole, and it would be repelled from the positive pole. So then we would have a charge concentration difference. How to determine that? Well, this equation would determine that for you. So this is what's referred to as the equilibrium potential for that ion. So we call it E sodium or E potassium in general, because you can calculate it for a single ion. The problem with this equation is it doesn't tell you how permeable the membrane is. You can have a concentration gradient across the membrane, and ions aren't going to move unless they can get across the membrane. So there's another equation that's used to understand that. But real quick, one can put in these values like the gas constant, Faraday's constant, and you can plug in different temperatures. And at 20 degrees C, for example, this temperature's in Kelvin, it'll come out to be something like 58 log. Convert the ln to log, it's easier to work with. And if one does that, and let's say you put in 5.4 millimolar saline in the bath, in the extracellular side of your preparation. But you don't know what the internal concentration is of that ion, unless it's maybe the squid where you could squish out the cytoplasm and put it in yourself. That's what they did back then. But for other cells, like our cells in our brain or our muscles, if we can't figure out what the concentration is inside, you can back calculate this. One can measure the potential, let's say it's -70 millivolts, and at the right temperature, and then plug in the concentration on the outside, you can back calculate the concentration on the inside. And in this case, it came out to be 86.95. One can put that value back into the equation, put it in here, and then calculate the potential. And then one comes up with -69.999, which is close enough to -70 that we started with. So this is the way to work this equation back and forth, and this is the way this equation is used even today to kind of calculate what internal concentrations of ions are. The problem with this is that cells are not just permeable to potassium only, that they can be potentially permeable to other ions, and so one came up with this other equation called the Goldman-Hodgkin-Katz equation by these three people. So they call it the GHK equation for short. And what's the difference from the Goldman-Hodgkin-Katz equation compared to the Nernst equation is that you see P in here. P is the permeability of the ions. And then you see that the Z is gone over here because these are +1 charges, so that's okay. What they've done here is to flip the in over the out for the chloride, because that would have been a negative Z and you can't work it out this way. So the way to work out the algebra is just to flip these two factors here in the equation. Let's say you want to put calcium into this equation because cells are permeable to calcium, especially if you have a channel that's calcium permeant. And so then you can draw this line on out and say plus permeability of calcium to the concentration of calcium out. But remember, calcium is a 2+ charge, so the Z would be a 2+. How to deal with that in this one equation? Well, then you put the concentration of calcium to the half power, so an exponential to a half power. And that way you can get rid of that Z of 2 in the beginning of the equation and have it all written out. So you might see Goldman-Hodgkin-Katz equation with multiple ions, and you then know why that they flip this out. It's not a typo in the paper, and then why they might have a half power to the calcium. So what does this allow one to do? This allows one to work out the membrane potential, equilibrium of the membrane for multiple ions, and understanding the permeability of those ions. So let's say the cell is not permeable to chloride or sodium. And just for an example, so if P is 0, this drops out, this drops out. And if P is 0 for chloride, this drops out, this drops out. And what do we end up left? P potassium here, these two cancel out. And we end up back to the Nernst equation, basically, but just for potassium. So you get the idea of how the Goldman-Hodgkin-Katz equation works and the Nernst equation works. This is an important fundamental concept in neurophysiology. Okay, so let's go over the action potential, and we'll have some other presentations on the action potential as well, but I just want to make sure everybody's on the same page. We see here in this diagram E potassium. That's the equilibrium for potassium. This is the equilibrium for sodium. If we have sodium channels, if the membrane is permeable and sodium channels open, we're going to go to the E sodium. That means the membrane wants to go to the equilibrium potential for that ion. It wants to go to E sodium. If the cell is permeable to potassium, the cell wants to go to the E potassium for the membrane potential. Okay, not all cells are at resting membrane potential, as shown here with this dotted line. They're not at the E potassium. Why? Probably because there's some leak of sodium. The cell is a little bit permeable to sodium at rest. So if it's permeable to sodium, it wants to go to the E sodium. So our resting membrane potential is generally, not in all cases, but in most cases, it's a little bit above the resting membrane potential is above the E potassium. So now we have the resting membrane potential at this value. If we give a stimulus, inject some current, or you're at a synaptic level, and some receptors open up on the membrane, and let's say they are ion channels, like at your muscle, acetylcholine receptors that open up, they're going to allow some current to come in. That will depolarize the membrane, and we begin to see this depolarization. But once we hit a particular level, which is the threshold for voltage-gated sodium channels, then those all open very quickly. And then, boom, the sodium rushes in and wants to go to E sodium. But it doesn't go all the way to E sodium. Why? Multiple reasons. Sodium channels show an inactivation. As they open, the structure will change its conformation and they will close, but they'll be in a state which we call inactive state. In addition, voltage-gated potassium channels will start to open up here somewhere during the membrane depolarization. Well, if they open, where's the E potassium? Down here. So if they open, we have a large driving gradient for potassium to leave the cell, go towards the E potassium, and therefore it brings the action potential back down. It may even go below the resting membrane potential, and when you see this, you know that E potassium is below the resting membrane potential because that's what's driving it that way. And then with the sodium potassium pump, in the voltage-gated potassium channels that used to open during the depolarization but were no longer depolarized, so the voltage-gated potassium channels will start to close. And then we go back to the resting membrane potential. Okay, so this is a little complicated because what we just went through was talking about voltage-gated sodium channels, voltage-gated potassium channels. But we were talking earlier about the membrane being permeable to potassium, and that's why the resting membrane potential is close to potassium. These are considered leak channels. So leak channels are termed as monovalent cationic ion channels. Monovalent means single charge, so +1, right? And cationic, potassium and sodium, because they're plus charges. So the leak channel that's in the membrane is a different type of channel than the voltage-gated potassium channel or the voltage-gated sodium channel. These are considered channels in the membrane that leak potassium out and leak some sodium in. Why does that happen? Because the concentration gradients are so great. Sodium's high outside the cell compared to inside the cell. Potassium's high inside the cell compared to outside the cell. So they want to go down the concentration gradient, but we do have to think about the electrical gradient. If the cell is negative, then potassium would be attracted to stay in the cell, right? Because it's a plus charge. And if the cell is negative, and if there's a little leak to sodium, sodium would want to go into the cell to the negative charge. So you see it's a concentration gradient in the electrical gradient that drives this leak channels to function the way they do for the ion movements. Okay, so you should be familiar with what E sodium is and E potassium is and how the shape of the action potential comes about in general. Okay, if we do something such as change the threshold of the voltage-gated sodium channels and make them more sensitive to the voltage, then we've dropped the threshold, and we could basically reach threshold easier with a smaller depolarization. And if we changed the inactivation of the voltage-gated sodium channels, we could actually have a larger peak, right? It could go towards the E sodium if we didn't inactivate them so quickly. And we can also maybe change even the duration of the action potential based on the density of the potassium channels that are in the membrane. It could either come back fast, or if we don't have as many potassium channels, it might come back. If we don't have as many potassium channels, it might come back slower. There's also this hyperpolarization after the action potential. If we have a potassium channel that is of a type that would open up in the presence of calcium coming into the cell, let's say we have voltage-gated calcium channels here, so calcium comes into the cell because it's high on the outside, and if you had a potassium channel that was a calcium-activated potassium channel, that means calcium comes into the cell, that could then activate a potassium channel, then that might cause it to have this after hyperpolarization, right? Because if you open up a potassium channel, it's going to want to go towards there. If we have fewer of those calcium-activated potassium channels, we might not see that hyperpolarization afterwards. So these are some factors to think about in the shape of the action potential. There's this really online neat calculator that one can use, and here's a website, and you can plug in these values. Now here, this is for, say, crayfish neurons from this paper that was pretty well described. You can put in these different values for P and temperature. Watch out on the temperature because it's in Kelvin, so you just put plus whatever the centigrade is, and then you can put in temperature. What's nice about this is you can change the concentration on the outside of potassium, for example. That little O is for the out, I is for the in, and you can see how that changes the membrane potential. Watch out down here, it's either in millivolts or volts. Maybe it's easier to watch that in millivolts because that's the way the textbooks usually refer to the membrane potential. So it's fun to play with this calculator and then try out different values. And so you can understand how the membrane potential changes with permeability for potassium or permeability for sodium. Change the concentration of potassium outside and see what happens. Or decrease the permeability of potassium and see how that affects the membrane potential. And that's important for this lab that we're going to work on. So have some fun with this website and play a little bit. Okay, so in general, this is very general, if we look at the membrane potential on the y-axis here, and on the x-axis we look at external potassium concentration. This is a kind of common lab done in neurophysiology classes and animal physiology classes. You put an electrode inside of a cell and you get the membrane potential. Let's say it's minus 80, for example, and the concentration of potassium in the bath is 5 millimolar. Then you add or switch out the saline to a higher concentration of potassium, and then you measure the membrane potential again. And we find out it follows pretty well the Nernst equation for potassium, because the skeletal muscle in general is mostly permeable to potassium, but there's some deviation depending on the animal preparation. If we go to real low potassium concentration, it's not just the potassium that's the major contributor anymore, but also the sodium that can flux into the cell. And so the sodium has more of a role. So it's better described by the Goldman-Hodgkin-Katz equation than it is the Nernst equation. The take-home of this slide is that as you raise external potassium, the cell membrane depolarizes. And this is through the leak channels generally. Just by changing in the Nernst equation, if you want to, you can put in a higher value of potassium, and you'll see that the equilibrium potential for potassium goes up, depolarizes. So therefore, the cell will go towards that new value. Okay, what maintains a lot of the membrane potential is that we have this leak of potassium out of the cell, going out of the cell, and some small leak of sodium going in, but the sodium-potassium pump, which ATP from inside the cell, adenosine triphosphate, drives this pump. So it's an energy-demanding process to keep sodium being pumped out and potassium pumped in to try to maintain the resting membrane potential. A very energy-demanding process. And this is important even in the MS study that we're going to be doing. So think of the energy demands on the cell for maintaining membrane potentials. Okay, so we just went through the shape of the action potential, the undershoot, rising phase, peak in the falling phase, and the threshold, just to see this in a colored diagram. The point I want to make here is that we just talked about reaching threshold and opening up sodium channels, and we see in some textbooks and some figures it just says sodium channels close. I want to make the point it's not just close. The proper terminology would be that they're inactivated. They're closed, but they're inactivated. You can't open them again until the membrane comes back down to rest for some period of time. And then it changes the conformation of that protein structure and allows them to be voltage sensitive again so they can open. This is the reason for the absolute refractory period. You can't stimulate another action potential when the sodium channels are inactivated. Even if the membrane comes back down, it still takes some time for the protein structure to change its conformation and be ready to open again. So if you gave another stimulus right here, for example, you might not get an action potential at all, even though the membrane potential is back down. This is what's referred to as the absolute refractory period, the time you can't stimulate a second action potential. Now let's say we waited a little bit and we gave another stimulus over here, we might get a small action potential. So that's just the beginning of the relative refractory period, until sometime when we give another stimulus and we get a full-blown action potential again. That time period is considered the relative refractory period, which has to do with the sodium channel inactivation. Okay, so now we've got a little bit more detail about the shape of the action potential and what limits multiple firings of an action potential. Went through this relative refractory period and absolute refractory period, talking about the shape of the action potentials and why the second stimulus might not give rise to an action potential because of the inactive voltage-gated sodium channels, where we can get a full action potential later on. When we think about the axon, we have to think about, we got these voltage-gated potassium channels, voltage-gated sodium channels, voltage-gated calcium channels. We just went over the calcium-activated potassium channel, which can give rise to that hyperpolarization. the membrane potential is maintained by the sodium-potassium pump. We also have these leak channels that leak sodium in, leaks potassium out. And then we have a calcium pump. That's pretty good. And the calcium pump will pump calcium out against the concentration gradient, just like sodium being pumped out across its concentration gradient, and then potassium in against its concentration gradient. There's another protein called the sodium-calcium exchanger. Now, an exchanger does not require ATP, so it's an exchanger which would exchange calcium out for sodium in. It's an exchanger that will exchange calcium out for sodium in. So sodium's high on the outside, and so is calcium normally, right? But since they're an antiporter, it's not functioning if calcium's high outside and sodium's high on the outside. But as soon as calcium comes in, now we have a concentration of calcium in the cell, then calcium can go out and sodium can go in. This can actually depolarize the cell even more because that's sodium going into the cell. Something to think about. We just want to mention it here, the sodium-calcium exchanger. Okay, now if we think of a myelinated axon and a non-myelinated axon, let's just think about what this myelin does. This myelin, this insulating sheath that you've probably heard of before, is that it can insulate this axon so we don't have negative charge built up in here. Remember, if the cell is negative on the inside and positive on the outside, it's going to attract positive charges here and negative charges here. So having this insulation decreases the capacitance that builds up on the membrane. And then it would be here at these nodes that we see this. Well, what this allows is the electrical event to jump from node to node to node very quickly. So this is what's referred to as a saltatory conduction of an action potential. But if we have an unmyelinated neuron, where we have charge built up on the inside that's negative and positive charges built up on the outside, it makes the axon slower in conduction because it has to neutralize this charge as the electrical flow goes down the axon. That's the general point about the myelination in this case for electrical conduction. Okay, now let's just think about the node in the internode region. We can also divide that up and call it paranoid. We can also divide this up and call it the paranodal region and the juxtaparanode region. So next to the node. So what's interesting is here is this blue that you see here. This is the myelination around this axon that's darker blue in here. We see different types of channels localized in the nodal region than we do in the internode region underneath the myelin sheath. So there's different types of channels that are localized in these different regions. This is important in multiple sclerosis and the treatments of multiple sclerosis. This might be hard for certain drugs, compounds, to get in here and work on these particular channels, like block them or activate them when myelin's around it. But if you take away the myelin, then there might be more accessibility to pharmacological agents to these particular channels. There's a lot of research in understanding how these channels aggregate in the certain regions, like right underneath the nodal region or in the internode region, and how do they get sorted and how do they stay in their locations. So that's a whole research area many people are studying. So let's look at the types of potassium channels here that we're talking about. If we had voltage-gated potassium channels, maybe different types, one that might be a 4AP sensitive one, like this green one. If we gave 4AP, what would happen to this particular potassium channel and the shape of the action potential? If these potassium channels are to bring the action potential back down, but we blocked some of them, what would happen to the shape of the action potential? And what would happen to the nerve terminal, where calcium comes in and actually causes the vesicles to fuse to the membrane to release their neurotransmitter? Well, let's think about that. If we started to have the permeability to calcium ions and the membrane permeability at the nerve terminal, okay? Okay. And in addition, the action potential is actually made up of not just one type of voltage-gated potassium channels, but many types of voltage-gated potassium channels. So here we see this is the names given to multiple types of potassium channels. The one we might be most interested in right now is this Kv3. This is the different thresholds of when these channels open. And here is our calcium-activated potassium channel, for example. And when calcium comes in, then it opens and it gives rise to this after hyperpolarization. So in some cases, they say that if we have an increased potassium channel activity that can bring the membrane down faster, then it could be ready for excitation quicker. That could happen. But if you have a calcium-activated potassium channel and bring it down and it stays hyperpolarized for a longer period of time, we could decrease the activity. So you see, it depends on the type of potassium channels that are present in the cell for its repetitive excitability. If we had more of these type of channels that keeps it hyperpolarized a longer period, then it would be less active. If we have more of these types of potassium channels and we don't have these around, then it could bring it down and be ready for the next firing, because it could remove the inactivation of the voltage-gated sodium channels quicker. So let's think about some of these different types of potassium channels just for a few representative examples. If we see this particular one, like this Kv4, it will open up, it's voltage gated, it will open up quickly. That's what the little V is for in here, they're voltage gated. It'll open up quickly and then it inactivates like a voltage gated sodium channel. You can see here the membrane is actually depolarized from -90 to -30, so it's depolarized this whole time. This particular potassium channel opens and then inactivates, and it won't activate again during this constant depolarized state. So that's kind of interesting. Then there's these slower type that you change the voltage, but they don't change their conformation so quick. So as a population, more and more open, and then when you stop the depolarization, they will close and come back down. Whereas the Kv1 type of potassium channel, it opens right away and it stays open until you turn off the voltage, and then it will come back down. So you get the idea. There's different types of voltage-gated potassium channels with the kinetics. There's also different types for the voltage sensitivity. Look at here. These don't open really until you depolarize it at a much higher level. So Kv3 takes like the peak of the action potential really before they will start to open up. So you have to depolarize the membrane to almost 0 millivolts. Whereas the Kv2 could be open at a lower voltage, but then as you go to a higher voltage, you'll get more conductance as well, and you get more potassium to go out of the cell. So you get the idea. Kv1 could be activated here, Kv3 here, Kv2 at some other point in time, maybe when it's, after it's opened it, but then not super fast either. Okay, so the timing's a little different. When you think of the action potential here, we're talking about a millisecond. And then we think about the location of these particular types of channels on different neurons. Let's look at this myelinated one first, the A fiber type of neuron. We see the myelinated nodal regions. You see the soma here, the axon, and we already talked about there's regional differences as shown here, and the node, paranode, and underneath the myelin sheath. And we see the BK calcium activated potassium channel over here. And we see that there's a different distribution of these ion channels. Now if we look at the unmyelinated C fiber, which is basically like a pain fiber without a lot of wrappings of myelin, we see that there's a more equal distribution of these types of potassium channels. There's also different ones that are in the sensory endings, like in the skin. This is the ones where you touch the skin and they would depolarize and then give rise to an action potential that travels along the axon into your spinal cord. When you get in your spinal cord, for example, here, think at the nerve terminals where it releases transmitter, then there's different types of potassium channels here as well. So these are in the terminal potassium channels. And your microglia, which is important, so pay attention here, and your astrocytes have potassium channels as well on them. Okay, so now we see that there's a distribution of different types of potassium channels, and they can change the shape of the action potential. Okay, so let's go through some of the pharmacology that we see here. The two types of potassium channels, there's two general classifications, which is this rapidly activating and slowly activating type of potassium channels, and they can be separated by pharmacological agents. Let's think about this control, the shape of this action potential here. We give TEA, it broadens the action potential. This is a potassium channel blocker, so it doesn't come back down so quickly. It stays depolarized. The same with this 4AP one. So it broadened the action potential. But in other types of neurons, you give TEA, it doesn't really do that much. And the same with 4AP. So it's neuronal specific. It's different neurons function differently depending on the types of channels that are present. Now I want you to think about it here. If we give 4AP and we prolong the action potential, it actually decreases the excitability. Decreases the excitability of the cell by blocking the potassium channels. Okay? And the same with this case. They wash the preparation out. They give TEA. It slows down the repetitive firing of the cell when it's depolarized. So it's basically inhibiting the repetitive firing information by giving 4AP and TEA on these particular cell types. And we didn't really talk about it much, but the amplitude of the action potential might change too, depending on the drugs, right? Because it might come down faster or not so fast, and it might have time to have the sodium current going in longer without counteracting the potassium by potassium. So there's different factors that can happen, and that's what's shown here. But I want to just look at this for example. If you block the potassium channel, so it's like not having as many potassium channels, it slowed down the activity. Let's back up a few slides right to here. Here we have increased potassium channel activity, and in this diagram it shows it's less active. That's just the opposite that we just talked about. But you see it depends on the type of potassium channel. So I don't want you to get confused. This one is saying increased potassium channel activity of this one that keeps it hyperpolarized for a longer period of time would not allow it to be as active. So you get the idea. It really is not so generalized speaking. One has to speak specifically about the particular type of potassium channel one's referring to when we're talking about changing the firing frequency of the neuron and how it impacts that. One other factor to think about, and this is just another preparation in hippocampal neurons in the part in our rodent brain, is that there's different sensitivity of potassium channels to the pharmacological agents. This particular neuron, if we give 30 micromolar 4-aminopyridine, it broadens it a little bit. But if we go 2.5 millimolar, which is much higher than the micromolar, right? 10 to the minus 6, 10 to the minus 3, then we really broaden this one. The take-home of this paper was that they felt that there were two different types of 4-aminopyridine sensitive potassium channels. Some that had a high affinity, so low concentration would affect them, and others with a low affinity, so you needed a higher concentration to block those potassium channels. This neuron also, if you gave it TEA for the tetraethyl ammonium, then it would broaden it as well. Now, what's interesting too is it might change the threshold of activation. Okay, so these are really interesting effects that you might have the same type of potassium channel sensitive to the drug, but there might be different subtypes with different affinities for the drug. This diagram down here is to show what happens when you give cobalt. Cobalt will block the calcium channels. So if you block the calcium channels, calcium can't go in and it can't activate the calcium activated potassium channel. So therefore, what would happen? then we wouldn't have the calcium-activated potassium channel to have an influence on the shape of the action potential. Okay, so now put that together, how 4-aminopyridine might be working. If we block the potassium channels and we broaden the action potential, we can have the action potential broadened, be above the threshold for the voltage-gated calcium channel for a longer period of time, and that means more calcium would come into the nerve terminal and then cause more vesicles to fuse, and we'd have more transmission. So that might be a mechanism of 4-aminopyridine, right? So let's go back and listen to some other aspects.
A doctor may be thinking that this is some sort of demyelinating disorder, but you're trying to figure out if it's more peripheral involvement versus central nervous system involvement. There could be different things that cause nerve demyelination. So you have the different neuropathies, such as Guillain-Barré syndrome, Charcot-Marie-Tooth disease, or is this something more related to the brain and spinal cord? With the demyelinating disorders, could be the optic neuritis is causing the double vision. Could it be, Lyme disease? So there's a lot of different things that the doctor has to do in order to rule in or rule out different diagnoses. So the doctor will do special tests in order to rule in or rule out differential diagnoses. In order to diagnose someone with MS, it can take months to years due to the type of MS that the person may have. There are blood tests that can be done to look at other diseases that may be mimicking similar symptoms. You can look at antibodies via lumbar puncture, imaging, brain imaging using MRI to look at, lesions that are in particular areas of the brain that may explain the difficulties with walking. You can also look at evoked potentials, either with a visual stimuli or electrical stimuli, to look at the response of the stimuli and then the nerves, to look at how quickly the information travels down the nerves. That can also lead to the diagnosis of MS. So classmate Jane tells you that she is diagnosed with MS. There are 3 main types of MS. There's relapsing remitting, is where you have your attack, and then there's a remission period where symptoms disappear completely or partially disappear. There is secondary progressive, which is where you progress steadily with active and non-active states. There's primary progressive, which symptoms worsen over time without early relapse or remission.
So generally, when you think about MS, we just think about demyelinating disease and losing the myelin. Remember, this is when we're talking about MS, we're talking about central nervous system, the spinal cord and the brain, not peripheral nerves. Okay, so one needs to separate out peripheral nerve disorders, which related to a number of factors that you can see here. Even environmental factors such as lack of vitamin or, say, alcohol use. And then there's demyelinating polyneuropathies that you can see here. So these are peripheral nervous system disorders that might mimic some responses such as MS. Then there's the central nervous system demyelinating factors, and you can see there's quite a few of them. Okay, so this is to give you a overview of that there's many factors that can contribute to demyelination, either in the periphery or in the central nervous system. But what's interesting is with MS, they generally see these 4 characteristics that can be divided up. Is that they'll see an inflammation in the nervous system, central nervous system, such as inflammation. The blood-brain barrier is damaged. They might find these expanding lesions over time, as Anne mentioned, takes years. They might see this expanding. They might see those stopping to expand, smoldering, and then they might see new ones forming. So you might find these inactive lesions where they're not continually growing, and you can see where some remyelination has occurred. And so this is more for the MS, and you can see that this would take time over years maybe to completely characterize what's going on in the brain. And one can see here a breakdown in the blood-brain barrier, and one gets these factors that would enter into the system, such as macrophages, and macrophages will eat up the dead cells, for example. We can find that there might be factors released from the glial cells and supporting cells that are around the area. One can see there's different colors, that this is color-coded coronal section of the brain, and we see different lesions, such as the red is this demyelinating region, and the green they're showing as widespread white matter lesions, and yellow, as indicated here, is this remyelination. So they have to follow this over time to be able to get good imaging and understand what's going on to the brain. But you can see the wide variety of issues here. And then another example with staining, one can see proteins that are being localized in particular regions of the brain, and changes of not just demyelination, but this inflammation of macrophages into this region. Okay. So if we think about multiple sclerosis versus some autoimmunes, there's some characteristics that are similar in the sense that you're breaking up the myelin sheath, and this can be induced by multiple factors, maybe a virus, autoimmune disorders, neurotoxins that could have action on this and induce MS, for example. And even an autoimmune disorders would mimic very much like MS. So correlating, some people are correlating these two together in the way that they work on the neurons and have an impact. Okay. MS is also thought to be now causing a lot of energy demand on the neurons, such as when you lose that myelin and the cells become leaky to potassium and sodium, and you're getting action potentials to come in and not just a normal flow of ions, that this then requires the cell to work harder and harder to pump out the sodium, potassium back in, or even the calcium that comes in. And so it's causing an energy depletion inside the cell. If you overwork your mitochondria, you can make reactive oxygen species that are damaging to the cell. And that can then cause the cells to be damaged by these factors that are released inside the cell from overuse, not only in the neurons, but in the oligodendrocytes, because they'll be balancing out the potassium that's spilling out around the axons, but also the energy demand on these cells can cause reactive oxygen species in their mitochondria and cause them to be damaged. So now we'll have cells, not just neurons, that could be dying, but also peripheral oligodendrocytes. When they die, they can release factors that can be even more damaging to the cells around them. Okay, so this differential diagnosis, as Anne mentioned, there's this term called McDonald criteria that people follow generally for understanding that. The way to find out if the blood-brain barrier is broken down, they use this gadolinium actually injected in, and what they find out is that it can go across the damaged sites in the blood-brain barrier, and that helps them to know that the blood-brain barrier has been compromised. So it's one approach to understand there's a leaky blood-brain barrier by using this contrast with gadolinium and imaging with the MRI. Okay.
Classmate Jane tells you that she's prescribed this AMPRA, which is dalfampridine. It's an extended release form of 4-AP. It's FDA approved in order to improve walking speed, which also helps decrease the risk of falls. It is not a disease-modifying drug, but it helps with the symptoms of MS. I believe the clinical trials showed that some patients respond really well to this drug. About 42.9% showed improvement of symptoms, mainly walking speed, but some patients did not respond with any changes to this drug. It's not well known the exact mechanisms of this drug, but we know a little bit about how 4-AP does work. 4-AP is fat soluble, so it's able to pass the blood-brain barrier with the thoughts of being able to improve conduction of the action potentials in demyelinating nerve fibers, so increasing neurotransmitter release in the synapse of the neuromuscular junction, with thoughts of prolonging and broadening the action potential. But in the following slides, we'll talk a little bit more about how 4-AP is actually working.
So we see, coming back to this slide, if 4-AP blocked that potassium channel and had a widening of the action potential, then we'd open up more voltage-gated calcium channels and calcium increasing transmission. That's one approach that is thought to work here for more transmitter release. But also think about calcium could have an impact on the calcium-activated potassium channel, and if that happened, it could hyperpolarize for a longer period of time and be less active, right, for repetitive stimulation, because most nerve terminals will be repetitively stimulated to cause more transmitter release. All right, and remember where these potassium channels are located. The ones that are most sensitive to the formiminopyridine are thought to be a lot underneath the myelin sheath, so they might not have access to the drug when it's myelinated, but might have more access to the drug when the myelination is lost. And that could be variety, then some neurons being more affected than other neurons, depending on the condition or the disease state. So you had these questions about how does the pathology of MS complicate the matters of just thinking about formiminopyridine on potassium channels. Well, remember we talked about the energy demand on the neuron itself, so it's not just about blocking the potassium channels, but that energy demand is a problem as well, and then it could be affecting other cells like the oligodendrocytes that are damaged, and that can cause changes in what's being released around the cells to have an impact. Okay, so it's complicated. The situation of treatment of MS are to reduce the symptoms of MS because of the multi-components involved. In addition, as people age, they have different disease states that occur, like Alzheimer's and other conditions, just the aging process. So you have pathology on top of it, but if the disease states are becoming greater and greater, then you have to separate out like the age, the problems with aging itself, and then treating the disorders, but also looking at the benefits that are occurring in time at the same time the nervous system is aging. Okay, so if we think about the energy demand in that oxidative burst that's going to happen in, say, reactive oxygen species that we might get, but also this hydrogen peroxide that could be released, and we get OH radicals that are out that can be very damaging. So if that's occurring from energy demand in the cell, in time, the supporting cells, the oligodendrocytes, can be damaged. They can have more reactive oxygen species, release more OH minus, or reactive oxygen species, and even cause more damage. But there's also thoughts about the iron that can be released from oligodendrocytes, and iron can be toxic to the myelin sheaths. This is one reason they remove blood if you have an aneurysm, for example, in the brain, and that blood spills over the nervous system. They try to remove the blood as fast as possible because that can just cause more damage than leaving the blood there and just letting it be absorbed in time. So to get that iron level out of the nervous system and clean it out. But this would be happening locally in different regions if these oligodendrocytes are being damaged. Okay, and then in addition, one can see that at the nodal region and the perinodal regions that there's localizations of those particular ion channels. But what happens with demyelination is that they start to spread out as well. So demyelination is different. A neuron is different than an unmyelinated neuron. So unmyelinated neurons might not represent a demyelinated neuron because of the different properties that occur when they demyelinate. And this has been shown with antibody staining for particular channels, such as the Kv7 7.3 type right here, they see that the demyelinated one, that they get spreading of it around that region. And so it changes the properties of the distribution of the ion channels with demyelination. And that changes lots of factors. Then that's going to change the energy demand for maintaining the potassium balance, for example, not just at the nodal regions, but now along the whole neuron. And where are the sodium-potassium pumps localized, as well as, say, the sodium-calcium exchanger. One idea is that there's too much sodium coming in. If sodium comes in, that can cause the problems as well. But then also, if calcium leaks in due to depolarization of the membrane, and you get a calcium coming in, that can activate more depolarization by calcium going out and sodium coming in. And then we have even more effects. Remember, the sodium-calcium exchanger can work bidirectionally. If we have more calcium outside and more sodium inside, now sodium can go out and calcium can come in. So if we get a leak of sodium inside the cell, this exchanger works in reverse, because it's not a pump, it's an exchanger. And if sodium accumulates in here, sodium out, calcium in, calcium inside the cell can be quite damaging because it can induce apoptosis, cell-regulated cell death. And so now we have axonal degeneration. So multiple factors to consider in the energy demand and how that can change dynamics of ions in the cell and the driving energy that's going to be required to it. So you were to look at the literature and look at potential for aminopyridine effects in MS and controversies presented in the literature. Some of the literature is that if aminopyridine can, in some cases they noted, get underneath the membrane, but at a lower level than, say, in the nodal regions. So it might have an effect even on myelinated neurons, but not as much as it would in unmyelinated neurons. But there's also the breakdown of particular factors in keeping these ion channels localized in a demyelinated nerve. So to understand a demyelinated nerve, you really can't examine myelinated nerves for the treatment of MS. So we need models, better models, to look at demyelinated neurons induced, say, in rodent models to understand the pharmacological actions that take place. And so there you can go through this whole diagram here as it's going through these particular steps and understanding more about the situation and energy demand in what's going on potentially with MS. So the idea is that aminopyridine will block those potassium channels in the region that's becoming demyelinated and maybe won't allow it to be so altered in its properties, and this could help in some aspects. But you can see it's complicated because it might not just be decreasing the potassium coming in, but we're worried about the potassium leak as well that occurs. So that's another factor. And then this Dr. Baker presented a good case here in a journal that is dedicated to multiple sclerosis and related diseases. This was out in 2013. And he basically mentioned that there's no real clear reason why 4-AP is working in some of the patients, because there's controversy in how it's working in demyelinated states. In addition, he doesn't think that it's really a larger width of the action potential in the nerve terminal to cause more calcium to come in, to cause more transmitter release, because this takes a higher concentration of aminopyridine for this response to occur, much higher than would be used therapeutically in humans. And in humans, you just can't go by concentrations. It's given per kilogram of body weight of the person because it's going to diffuse in the body. So they actually give the drug in milligrams per kilogram of body weight, but it doesn't reach this high concentration. Aminopyridine at high concentration is toxic to the human body. It can cause epileptic seizures, but also affect the heart. So it's can be a dangerous drug if it's too high of concentration. And the aspects about binding in unmyelinated and demyelinated regions versus myelinated regions, okay? And the leakage of the intracellular potassium ions, they might not depolarize to the same level and give rise to action potentials. So this is another controversy of the 4-aminopyridine. It might reduce some of the potassium channel leak, but I'm not quite sure if that's the case, because that means it would have to block these leak channels. So if you go through the literature and you've come up with some ideas, we can discuss those now in the class and have some discussion about them. A lot comes back down to blocking these specific channels in the demyelinated region, the 4-aminopyridine sensitive channels, and like resetting the axon, allowing it to function is the general consensus. But there's something else that happens, right? So in the demyelinating disease in multiple sclerosis, it's an immune disorder and the blood-brain barrier is breaking down. They know that T cells, the myelin-specific T cells, can be activated, and these T cells that are activated can release substances that can be harmful to the neurons. These particular T cells are known to have voltage-gated potassium channels. So maybe by blocking these T cells that invade the area where the blood-brain barrier is broken down and actually having 4-AP work on them to stop releasing factors could be the key in how 4-aminopyridine might be actually helping MS patients. Maybe it's not directly on the neurons themselves, but indirectly through inhibiting the T cells function. Or maybe it's a little combination of both. So KB 1.3 cells, which 4-aminopyridine binds to, is on these T cells, and that way they might be helpful because then they won't release these destructive proteases called Gremz B that can actually damage cells. All right, so that's quite interesting. And just to make sure that we see this 4-aminopyridine blocks those particular cell types, potassium channel types, on those activated T cells. Okay, so from the readings of your knowledge, why would some people benefit from 4-aminopyridine where others don't benefit from 4-aminopyridine? Let's have that class discussion. What do you think? And this is the point that we want input from the class. Also, what do you think the next steps might be in addressing how 4-aminopyridine works to improve MS? And another class discussion would be great at this point. Potential therapies, we could look at this drug, Ampera, which is related to this 4-aminopyridine and the way it works. There's a really good video here I want you to watch, and also some real patient videos of how this drug is working and the effects of increasing their mobility in walking. So please watch this link here and watching some of these videos, and watch this educational YouTube link that's from this company that sells this drug. Okay, and to give some ideas about how this other therapies might be working. Remember, there might be some therapies in actually inhibiting the factors that block the growth and synthesis of myelin. These factors are released in the damaged cells, and so they might be better to actually help in treating MS and allowing the cells to somewhat repair themselves and remyelinate. So there's lots of interesting ideas out there. Maybe a combination, a cocktail of approaches might be an approach in the future to work with. And we do have to think about the sodium leak that comes into the cells and causes depolarization and intercellular calcium accumulation, because that can be quite damaging to cells. And so this is another factor to maybe think about. Maybe we can be blocking some of this sodium channel leakage into the cells and helping to reduce the energy demand on the cells. So you probably have some information yourself that you want to add, and thinking about this disorder in treatments.